Hello, I'm Dr. Spencer Skelton, a member of Colorectal Surgical Services. I'm board certified in general surgery, specializing in diseases of the colon and rectum and anus. Fecal incontinence is the involuntary passage of stool or gas when sometimes a patient is unaware, or even if they have the urge to go, they're unable to control it. Fecal incontinence develops as a result of several factors, one being weakness in the muscle, whether this is from poor muscle function, from a pelvic nerve problem, or whether it's an injury to the muscle itself. Other factors that play a role in incontinence include the rectum's reservoir capacity, how well does it hold stool, what is the stool volume, is the stool loose or solid or liquid, and what is the sensory mechanisms in the rectum that allow patients able to sense the need to go to the bathroom. Fecal incontinence occurs in mostly the elderly population. However, it's also common in women who have had multiple childbirths with possible childbirth complications, this being episiotomies or unexpected tears when the child is being delivered. This is often repaired at the time of delivery, but oftentimes down the road, as a patient gets older, they develop symptoms. The quality of life can be very poor in these individuals in that it oftentimes leaves them isolated to their home. If you can imagine going to the grocery store and having a bowel movement unexpectedly, this can be very embarrassing and concerning to patients. So oftentimes, once it gets to that point, patients do not go and leave their house. Oftentimes, fecal incontinence goes undiagnosed due to embarrassment and shame and reluctance to bring this up to their healthcare providers. Fecal incontinence is diagnosed with a careful history and physical exam. Factors on the history focus mainly on the patient's birthing history. How many children have they had? Were these vaginal births? And if so, were there any complications with the birth? Other factors that play a role in an individual with fecal incontinence include their anorectal sensory function and their pelvic floor function. How well do the muscles coordinate and how well does the body sense the urge to defecate? Additionally, there can be some pelvic nerve damage that leads to a poor muscle contraction. While the muscle may be intact, it doesn't receive the signals from the brain to squeeze. Fecal incontinence is treated in a variety of ways. Usually we begin first by making dietary modifications, increasing the stool bulk with dietary fiber or a fiber supplement. This often gives patients the necessary stool volume that they need to control their symptoms, if, for instance, their symptoms are worse with liquid stool. Other ways we can treat fecal incontinence are with surgery. This involves some diagnostic tests preoperatively, which include an anal rectal ultrasound as well as anal rectal manometry and an EMG recording to test the pelvic floor function as well as the pudendal nerve function. If these tests show decreased nerve activity to the nerve, then a sacral nerve stimulator may be a reasonable option. However, if there is evidence of a defect within the muscle, a sphincteroplasty may be a reasonable option. In the rare occasion, a colostomy is necessary to prevent you from having continual accidents if these other things have failed. This can be a very troublesome problem for patients, and there are resources to help. You should not be scared to seek treatment, as there are ways to improve your function.